Go.
Hey everybody, we had a few technical difficulties, but we're here now. We got in, and you missed the part where I thought maybe we had some people hadn't paid their electric bills, but that wasn't the case. I'm not naming no names. They got good government jobs and they get checks on the regular. I'm just saying. So first of all, I want to thank you who joined me here on this conversation today, but also those of you who may touch in with us on Facebook, Instagram, and on other platforms. So, one of the things that I wanted to do is to first of all honor Dr. Robin Fanfare and congratulate her on her new position. I mean, it's like, those of us that have been in the streets for a while know the people that have been in the streets. And are truly honored to see when folks are both recognized for their contributions, but are still in the fight with their contribution. So I just really want to say I'm so proud of you and congratulations. Now, I'm going to go out and do some, y'all going to do some brief introductions, but I wanted to have a conversation with y'all. I didn't want to have and don't want to have like a formal let's get 16 slides out conversation. I want to have the who are we, where are we, who that kid? You ain't got no kids. Where the kid come from? You ain't even got no kids.
I have 2 kids.
The other one.
No kids. Well, I guess now I know something I ain't know. And that's what I want to know. I want to know stuff I don't know. So first, I'm gonna do the introduction, and y'all can correct me. We already did Dr. Fanfare, right? Marlene McNeese is at the Houston Department of Health and Hygiene in Harris County, Texas, and has been everything from the hip hop coordinator to the HIV testing. Now, I'm gonna tell y'all the truth. The truth is that I met Marlene before she was the big boss. I don't mean just the big hair. I mean the big boss, right? Yeah, I mean, I remember I met Marlene when she was coming out of a CBO. And shall I give you a nickname here now?
That story is not relevant to our topic.
But I believe it is. But I believe it is. I believe it is because
Moderator privilege.
I believe it follows you to this day. Marlene is also the co-chair, for those of you who may not know, of the president. That's President Biden, not the president of the Dog Catcher Association, but President Biden's Presidential Advisory Council on HIV and AIDS. So, so I will spare her and give her some honor because of her, appointments and whatnot.
Today,
to not give her quote unquote street name. So
text it to me, Toni. Text it to me.
You got it. No problem.
Thank you.
Private chat so we all see it.
No problem. No problem. I have a problem doing that. So Marlene, would you like to say a few words about yourself? Because I could use that other few minutes with that name.
No, I am happy to be here with esteemed colleagues in the room today. It is such a joy to spend this kind of time together, and I am beyond excited about Dr. Fanfare. So I can't wait to hug your neck and truly give you a thorough congratulations. It means so much, not just for the competency and expertise you bring to the role, but for all the young girls and women around the country looking up to your success and what you've been able to accomplish. So I am beyond excited and thrilled. So can't wait to see you and can't wait for the rest of this conversation. It's starting off pretty lively already.
Yeah.
Well, thank you. So now we're gonna stay in Texas, but now we're gonna move on over to Beaumont now. Now she was right. She used to be. That's right. And you good. You better be grateful I don't put your street address because I got it now.
Thank you.
so, but Dena
and rural is small.
Rural is tiny, teeny tiny. I know they can they can do that micro or whatever it is. Where they So we don't want them to do. We don't want them to do that. Right. But Dena and Dena, I'm gonna tell a part of your story for you. But I mean, but you've come such a long way. Dena and I actually met because we got into an argument. I don't even know if you remember this.
Oh,
Isn't
please
that all
tell
your
me.
meetings, your intros? That's not all your
Easy,
intros?
easy,
Valid,
lady.
valid.
Easy. But no, you and I got into an argument. It was you, me, Marlene, and I think it was that other girl that married that other girl. I can't remember her name right now. Because you know who I'm talking about.
Okay.
Right? But we got into an argument because you decided in your own infinite wisdom you was going to take a drug holiday. And I said, have you lost your goddamn mind? What you think them people invented the treatment for?
And it
And
wasn't
you
even.
like,
It wasn't
no,
even.
you remember
Well, yeah, it was a
start
holiday.
you start thumping your chest. I can do whatever I want to do.
Oh,
Remember that?
can
You
you
remember?
please say something about it being 1990 something?
Okay,
Put that in here.
that was the truth.
That's
That was the truth.
context.
It was 1990. But you know, you listened to us and you went, maybe I should see a doctor. Like, yeah, that's kind of what they made the doctors for.
Really?
And then you
Really?
did that. But then also the fact that you became one of the faces of Black women living with HIV. And I'm going to say you became one of those faces that made people go, huh? And it was, and also, but watching you grow from that to running a FQHC that is really servicing people in rural communities. And like I always say, girl, I ain't never think you keep no job that long, but okay,
Amen.
here we go.
That part.
Amen. Amen to that. And look at you now. Tell the people who you are.
Well, hey everyone, and thanks, Toni. That was really sweet. I will, as we talk, there's some clarifications that need to go on, but as a person living with HIV for the last 33 years now, you know, it's definitely a testimony to education, testimony to lived experience, and you know the changes. So I'm really, you know, excited to be a part of this conversation with you ladies. And Toni, I will tell you, those arguments took place when I did not know much. I will co-sign on, didn't know a lot. And so being in the community and really having the opportunity to spend, you know, my work life with Marlene, to be able to spend, you know, all these years with you and Dazon, and to be able to meet, you know, new friends like Masara, Dafina, and Dr. Fanfare. Wow, hi. And Martha, you know, being with you guys, this has been a life's journey. You know, this has been an entire life's journey. So, and Tori, hey girl. But I'm really excited to be with y'all and to, you know, to have this conversation. And hopefully I might have a little bit more education than I did from that last chat we had. That's all I'm saying. That's all I'm saying. But thanks for inviting me, baby.
Well, there you go. And so I'm gonna switch over to the ATL for a minute. And the infamous, famous, impactful Dazon Dixon Diallo. And Dazon, I don't know if you know when we actually met. We actually met when I was with the National Women's Health Network, and I came across the country doing focus groups with you, Pan, and a couple of others before I even started the National Women and HIV/AIDS Project, which became Community Education Group. And that was 30-something years ago. So I don't think you need a whole bunch of intro because everybody know you if they got any common sense. But you know, all sense ain't common. So what you want to tell the people about you?
I'm Toni's friend. Most days. There were a couple of years in there where it wasn't show. But
who on this call can't say that? But go ahead.
Exactly. This is my tribe. So this is the We Know Toni tribe. So Dazon Dixon Jallo, founder, president, chief culprit at Sister Love, based in Atlanta, and Sister Love International, South Africa, based in Johannesburg. And this, folks, is my 40th year in the movement work, sexual and reproductive health, rights and justice, and my 39th plus year in HIV. And I don't know what else. Co-founder of Sister Song, current End AIDS Coalition. I host what I think is probably one of the funnest, bestest, most amazing solidarity building meetings in the world called Women Now. which happens every 2 years on the continent, 2025. Keep an eye out because we'll be looking for you to join us in December of 2025, wherever it's going to be. And Sister Love is 35 this year, and I'm excited about that. 35, which means I am long overdue for us to have a new ED. So we're working on that. But what I will say this, that what I think is important about all of what we're representing here today and what we set out to do 35 years ago is to make sure, obviously, it was to just fight against this scourge at the time, which was AIDS. But as we evolved and understood how HIV sits in the spectrum of women's lives, especially Black women's lives, we set out to bring HIV into the sexual and reproductive health rights and justice space, and to make sure that the sexual health rights and justice work commingled, crossed over, or whatever into the HIV space. And so we've been doing that ever since, from day one. And I think we are reaching a certain critical point where if we don't have it all together to make sure that all of these issues across the spectrum of a woman and femme identified people's lives are impacted by sex and sexual health from the very beginning of life to the very end of life, we're the ones who are going to do it. So I'm grateful for this conversation because y'all know I start out this way and end this way. Black women, we gave birth to humanity and we will save the planet. And a part of that is in the epidemic. It ain't going to end without us. And so I don't talk about key populations or priority populations because we are an essential population.
There you go.
Perfect. All right. Now I'm going to introduce Tori Cooper. Now, Tori, we met in this room, really. I mean, we knew each other, but you came to this meeting I had.
I thought you were going to tell them we met at a sex club or something.
Okay, listen, why you got to tell everything? That's why people don't tell you shit. Because you tell
about to tell. See, you were about to tell everybody else.
Some people don't tell you everything. That's why they don't tell you everything.
Go ahead.
You don't know how to hold water.
Because let's tell her business, Tori. That's what that is. See, that's what that is.
But Tori came to this meeting, and I knew Tori didn't know why she was at this meeting at all, and was like, "Why am I in this meeting with these people in this room to talk about this rule stuff with this person I don't even know?" But the thing that it was, I'm gonna tell y'all a funny story, and this is a funny story about me. So, in the middle of the meeting, Tori say, the folks that are non-binary, and I was like, "Who the fuck are they?" And she said it again, and I was like, "Who she keep talking about?" And I leaned over to the next person that was next to me, and they said, "She talking about you," and I was like. Let me write that in my notes for today. Go ahead, Tori. Welcome to the group.
Well, thank you. Always such an honor to be amongst so many wonderful sisters. And Toni, I love it. Dr. Fanfare, congratulations again. I look forward to hugging your neck as well. I do a whole bunch of things in the community, and hopefully they're impacting a whole bunch of people in a wonderful, wonderful way. And that's it.
Perfect. Now I'm going to give you Martha. Now, Martha and I have known each other since she was in D.C. Now she all over the globe. Martha be looking at me funny, like, rah. But the other thing is that the truth is that I always was like, look at her. She was like rocking in the research little space. And it was like, and the other thing is like people weren't paying attention, but Martha be coming there with the facts. And then saying and speaking on behalf of women living with HIV, but with the facts, not with hyperbole, not with drama. Like, no, here just the facts. Now, go ahead, Martha. You tell these people who you are.
And I do have 2 kids.
I didn't know you had no kids. Who knew?
And both of them were born since I've been HIV positive, 12 and 14. And so I am honored to be here. The other day, I was in a meeting where we were celebrating Dr. Fanfare's appointment. Well, there was like two meetings, a caucus meeting, a United meeting. And then I went into this other meeting where they were not talking so nice to me. And, I thought to myself, I said, today I just heard that Dr. Fanfare has been appointed, and you can't say nothing to me. When you know someone important and you know that they're representing you, yeah. So thank you. It means so much to us that you are appointed. And I'm all about this research and how it impacts women living with HIV. The DC data came out last week for 2022, and we have actually had babies being born not only with HIV, but with congenital syphilis. So I'm just going to say we have work to do. And so I'm glad to be here so we can talk about it.
Perfect.
Thank you.
Thank you, Martha. And last but not least, let me tell you about Dafina Ward. Listen, let me tell you, everybody was like, y'all don't like each other. And I was like, ain't nobody, I don't even know that lady. What you talking about? I don't know that lady. That lady don't know me. I don't know that lady. But then me and that lady started talking on the regular, and guess what? Me and that lady like each other. I like that lady. That lady got passion. That lady like, Now, okay, now I might admit a little part of me was like, CEG gonna be in the rural community. We gonna kill Zach. We gonna kill. And I was like, why are we gonna kill him? Why don't we just work with him? Why don't we collaborate? Why don't we do what we supposed to do? Why don't we, why don't we take over the world? Why don't we do that? What's up, Dafina Ward?
Toni, I'm glad you realize you like me, and I like you. You a mess, but I like you. I think part of the conversation we have to have is the fact that we can't let folks pit us against each other.
Right.
Yeah.
And we got to lean on each other and love on each other and do this work together, because Black women gonna have to end this together. But I'm Dafina Ward, Executive Director of Southern AIDS Coalition, based in South Carolina. And, Dazon already said, like, Black women are gonna have to save the world, like we've been doing. We're gonna have to end this epidemic and all the disparities. And we also gonna have to end in the South. And we don't end the national epidemic in this crisis if we don't end
in the South.
HIV in the South. And so that's my commitment. That is our mission. That is our focus. And we know we can't end HIV disparities and all the health disparities in the South if we don't do something about systemic racism, all forms of oppression and discrimination. All that's going to have to go. And that's how we're going to have to end it. But we're going to have to lead the way. I'm just honored to be here. I have had the chance to hug Dr. Robin Niblett Fanfare's neck. And we might have danced to some Cardi B. I don't know. That might have happened. But I'm just honored to be among all you beautiful women. Happy National Women and Girls HIV/AIDS Awareness Day. It is a beautiful thing to see that there are so many of us leading in this work. And so we just got to continue to make our voices heard, make our demands known, and get the resources we need to end this thing, because we're going to have to lead the way. So thank you, Toni.
Thank y'all. But last but not least, Dr. Fanfare, tell these people who you are and why you're, who you are to us, to the world, and now to the federal government.
Well, thank you, everyone. I had no idea really what I was walking into at all. Got my rosé here. I'm not even sipping it. It's just like, it's so much love. It's so much love in this room. And I'm actually sitting here really fangirling. It's just really been very humbling to be, I'm Robin. I am at CDC, and I'm the first woman, obviously Black woman, to be the permanent division director of the Division of HIV Prevention. And, and with that, I really came to this work almost 20 years ago in Baltimore, and was really struck by the intersection of poverty and mass incarceration and clinical medicine and epi and research and so many things. And what we now know is syndemics, right? Doing work in STIs, if people have been talking about congenital syphilis. So it's really been quite the journey. And over the past 2 years, getting to meet and interact with so many of these, as I call legends, OGs, icons, doing this work in the game. And so I'm kind of sitting here as a little G, just really, really thrilled to be here. And I'm looking forward in Houston to those hugs. So thank you so much for that. And thank you for the opportunity, Toni, to be here with everyone and be part of this huge and critical conversation on this day. We didn't wait till the Monday. We did it on the Sunday, on the actual day, to represent our women and girls.
And thank you and congratulations again. And you are Dr. Robin Fanfare. You are not Robin. You are Dr. Fanfare.
Thank you, Mom.
And I believe that that's really important. And the reason it's so important is because, see, I think the once you give someone license to not honor your honorifics, they feel like they may have license to do something else. So they can't do it in my space, and I will not allow anyone else to do it in your space. So one of the things that most of the folks here know my story. My story is that we started out as the National Women in HIV/AIDS Project, and we evolved and grew into community education group. We then started our work primarily in urban settings, and Southeast DC was where I did the most of my work. For the last decade, we've really been doing work in the Appalachia region, 94, 96% white, high rates of poverty. But we have an epidemic that's coming, right? And that's here kind of now. And we have an epidemic that is an epidemic of a syndemic. But we also have one that doesn't have the infrastructure per se, right? That many other urban environments do. One of the things that I want us to talk about is, I think Martha kind of hit on it a bit, right? Vertical transmission. Many of us kind of got into the research and advocacy game around 076, clinical trial 076. And many of us kind of had a feeling about it or conversation about it. But what I want us to talk about now is where we think vertical transmission is in the United States and globally right now. And are we doing everything that we need to do to ensure that women who are living with HIV understand what their options are? But also, are we having a conversation about prevention that we need to be having in this space as well? All right, I guess that one went like a lead balloon.
No, I got a thought about that, and I think that, and that's because when we start talking about syndemics, and then we look at the multitude of what I don't agree with calling things social determinants of health. I think they are all determinants of health inequity, and they're not all social. Some of them are fixed, some of them are political, and so I think that the notion of being able to talk about vertical transmission in the context of overall maternal health is something that we have missed in our HIV movement, right? And that the movement, for example, for Black maternal health has left this conversation of HIV out of that. When we know, for example, when Georgia had the #1 highest rate of perinatal or vertical transmissions in the country, that was also concomitant to one of the highest rates of congenital syphilis. We also looked at the structural issues. For example, like 10 out of 11 delivery hospitals in the metro Atlanta were not following obstetric and delivery protocols around HIV. They weren't screening in first and third trimester for HIV and syphilis. They weren't doing the immediate screenings at delivery. And so there are a lot of issues that intersect with how we talk about maternal health outcomes that the HIV question has not been centered or not even included or incorporated in the ways that are going to actually improve things. So whether that's from a prenatal standpoint to, all the way to post-delivery. The second part to that too, though, and I know I've talked with this about Dr. Fanfare, and I also actually talked directly to the NPEN people and CDC communications, because we also are up against things like these so-called pregnancy resource centers, which we know are fake abortion clinics or anti-abortion clinics or crisis pregnancy centers that see people who are pregnant and are seeing people who are pregnant at a time when they're in crisis. And they are now not only judging and shaming and doing all of that around people who are not intending to carry their pregnancy to term, but they're also encroaching in on HIV and STI screening with no connections to services, with no referrals, with no prevention information, with not even prevention tools. And so now we're creating a situation where we're possibly increasing the risk of vertical transmission just because in the state of Georgia, for example, those organizations get $2 million directly out of our state budget.
Yeah.
So there's a whole idea of how we think and talk intersectionality in the maternal health space that we have not done well enough in terms of bringing HIV into that.
Oh, yeah, but would you suggest? I suggested that's probably true also in the behavioral health space, right? In the substance use
absolutely.
In the substance use disorder space, it's like we know the relationship of harm reduction to prevention of hepatitis and HIV, but we really haven't bought, that's the mission I'm on right now, is how do we bring in MAT providers, medically assisted treatment providers, those that are in small and mid-sized practices, to be a part of our continuum of HIV and hepatitis C care, treatment, and cure. Because I think that they put their hands on that 20 to 20%, 25% of HIV new cases we can't find. I think that they're in those clinics because they're not coming out to other places. And where in the case of hepatitis C, I think we have an opportunity to not just treat, but we also have an opportunity to cure. Okay, I don't want to get on that soapbox right there, but I want to kind of stick with this idea about what we know, what we don't know, and where things are now, right? Because again, I'm out here in West Virginia and in rural communities out here who don't have an infrastructure, right? Or that those MAT providers are that infrastructure, or Dena, like the community health centers, rural community health centers, Ryan White community health centers are the health infrastructure. How do we pull them in to this conversation that we really need to be having in 2024? Because it's not like it used to be where we could just go out in the corner, hand out a pamphlet and say, come in and get a test. That's not how this is working anymore. What do we need to be doing? What's yes?
So may I comment a little on that prevention part of the question that you asked earlier? I think that for many Black women, even today, that Black women, Black cis and trans women, Black femmes who are non-binary, however you got to your womanhood, I think that many of us still don't see ourselves at risk of being of getting HIV.
That's right.
In part because of certainly who we're having sex with, not just the kind of sex that we're having, which plays a role in it too. But if you're a woman who's in a relationship with a man who says he's only having sex with you, then one assumes that there's no risk for contracting HIV. And if you're in sexual relationships with 100 men who say they're only having sex with you, it's the same thing. And so because we don't see ourselves at risk, it actually puts us at greater risk. And that's a trigger word right there, that risk word, but it's true. It makes us more susceptible to getting an HIV diagnosis because we, as communities of Black women, don't think about ourselves at risk. And then healthcare systems, in spite of all the data, Martha is an incredible researcher. In spite of all the data, medical systems don't see us at risk. Now, after a positive diagnosis, they say, oh, well, you were at risk then. But when it comes to prevention and possibly preventing an HIV diagnosis, they don't see having conversations around PrEP modalities or harm reduction. Since you mentioned harm reduction, they don't see that as an option for Black women. They say, oh, you're not going to take it anyway because you don't take this birth control pill. Oh, you don't take it anyway because you don't take this pill for high blood pressure or for diabetes. Oh, you're not going to take it anyway because X, Y, and Z.
But let me ask you, okay, now listen, I'm getting ready to throw the gasoline on the fire. And y'all, if you need to just hang up, and I'm not going to get upset with nobody because I know everybody's trying to keep their job. And some people just got them. I ain't naming no names out of the fanfare. So here's the thing. How much of this do you think is because, so here's what I think. Okay, let me tell
finish
you
your question. I was ready to answer it before you.
Okay, but wait, hang on. But let me get. I got. She messed me up when it took me down a whole nother road. Y'all know I got attention deficit disorder. So here's the thing. So this is my question: how much of this has to do with the lack of conversation that we have about Black men who don't identify as same gender loving in this conversation? Because I say, for example, I was just, and he might be watching today, but I was having a conversation with Daniel Driffin. And what I told him he should do at IAS is go to every presentation that has Black men in the slide deck and then take a picture of that slide deck, right? When you see those little scales, be Black men, Black women. Now, when you're sitting in the audience, there's some kind of assumption that those two people had something to do with each other, that those two lines got something to do with each other. And I'm like, I don't know them people ever met each other, number one. Number two, can we then pull back that science, that data that they're showing us, and talk to us about whether or not those individuals that are in each of those groupings have identified as same gender loving, haven't had sex with a woman in the past 12 months, or what? Because the assumption becomes that these two groups of people have something to do with one another sexually, and they generally don't. And we don't really go out and say, let's have a conversation with the man who is saying, I only have sex with women. Whether I'm not asking you anything else other than that, because how are we going to get Black women to uptake PrEP really if we're not talking to the men that they're sleeping with? And how are we going to get them to have this conversation more honestly if we don't talk to the men that they're sleeping with? Now that's just me. Now that maybe that's because I'm me, but okay, go ahead, Martha. Go ahead, shoot holes in everything I just said, Martha.
Well, when you find the trick to talking to those men, you will need to let everybody know, because
I got a plan.
Okay, globally, in Africa, we know that the burden is on the cis and heterosexual women, and everybody says they don't know who they're sleeping with because there's more numbers, in the women and so on and so forth. And, I think the LGBT community doesn't exist in Africa, or they're shot and killed or jailed. But over here, one of the things I say is, for somebody to transmit HIV, it means they're either untested or they're not virally suppressed. And so I sometimes wonder, when we boast about the testing and treatment that we've done, if we'd really done enough. That's always my question. Because for there to be a transmission, it's starting from somewhere. And for some reason, prevention just doesn't seem to be catching the people that are actually transmitting. So when we're talking about prevention now, we go into the regular community, but I don't think we're doing enough of what I believe we used to call the prevention with the positives. That was actually a CDC thing that seems to have disappeared. But I kind of wanted to take a step back and also go back to when we're talking about pre and postnatal and all of that, and just want to really acknowledge that we talk about this at a national level about sex education and prevention education among young people, and a lot of people are trying to do it, but I really don't believe we're doing enough of that either, and I don't know how to change that. But since we're here in a group that talks about community education, maybe we'll get somewhere. Mm-hmm. Because these new transmissions are among younger people, and apparently when they're testing, even for the syphilis, the person who they're testing has no idea that they had syphilis, and in some cases don't even know what it is to start with, is what I heard.
Come on in.
Dazon, let's let Dr. Fanfare.
Yep. So just really quick, I wanted to just piggyback on what Martha was saying and just kind of take a beat for a second with that first question and say that is a success we've had nationally, right? The elimination of perinatal transmission, or meeting that criteria, is a success we have had. If we think back when it was over, 1,000 babies being born with HIV every year, and now we're at fewer than 40. So while that's a success, we still see vast disparities, right? Those babies who are being born with HIV continue to be our babies, right? Those continue to be Black babies. Yes. And then I think also, as we think about and rest in power Hydea Broadbent, ensuring that these lifetime survivors and dandelions who are born to this day, that we continue to have them in conversations, especially as now we start to think more about HIV and aging, right? We couldn't necessarily have that conversation 20 years ago, 30 years ago, but now we are having a conversation about HIV and aging and quality of life. And so I think that that's a success in the United States, but the vast majority of the burden is still on our babies. And then globally, as I said, I just gotten back from Denver. Croy was in Denver this year. So a lot of incredible global work that was presented. And I want to get the number right, but I believe it was still over 100,000 babies who are born globally with HIV. So a lot of work that still needs to be done globally. And I think Martha hit such an important point that I just want to also center it. Treatment as prevention and U equals U. I do think sometimes the conversations have gone in certain ways, and we want to ensure that we're making them all in tandem, right? There's testing, there's PrEP, which is incredible, but that treatment as prevention and U equals U for people living with HIV is extraordinarily important. And we want to make sure that we're centering our programs, activities, policies, et cetera, to ensure that that's highlighted as well.
So, Dr. Fanfare, now, you started talking, so now I got to come back to you, right? So here's the thing. Let me ask you this. So, we've got ending the HIV epidemic, but really, there are 4 pillars of the ending the HIV epidemic strategy, or EHE as they call it. For you taking this job, what are your priorities?
Well, I love that question. I think the question is really timely. I would just say that this week is the week that I'm rolling it out to our division. So I really want to make sure that I'm rolling out those priorities internally to our division. And then after that,
what you saying? You can't tell us first?
I mean, I think we're on in certain places. I don't know if this is just us. But in the next few weeks, definitely ensuring that we're rolling it out with our external partners, doing a few interviews as well. But I think a lot of what has been already hit on today really highlights some of those priorities.
Well, and I think I'm asking you for 2 reasons. One, and I understand that you want to maybe talk to the people that you work with first. Funny, funny how you might want to do that. But the other reason is that what I want to make sure I do, and I think the folks here do, is that we support that mission, right? And that we are there, and that you see us as community partners. And I think that often many of us really try to make sure that we are in partnership. And I think sometimes folks can see community as an adversarial relationship rather than a collaborative relationship. So most importantly, I just wanted to put that out there, and I'll speak for all of them because I can, and it's my meeting. And so,
absolutely.
Yeah. And so, Marlene, you the government. What the government doing?
Yeah. But I am the government as we stand today. And I wanted to unpack your question because I too had to take a beat and think about it a bit deeper. And really the crux of the question that landed with me is how and why does transmission of disease continue to occur? And in certain groups, as we all on this call know today, it's really disproportionately impacting, us, women and girls. That's why we're having this conversation on Women and Girls Day, particularly African American, Hispanic women and girls, but also for the young and continues to get younger every time we look at the data for gay and bisexual men. The reality is in the seat I sit in, and I so happen to sit in the state of Texas, without expanded Medicaid access to health care. And that being, to me, the crux of what's fueling why and how many people are walking around burdened by disease, infection. I say disease as dis-ease. There are many, many ills happening with Black and brown people. You named a lot of them early on, Toni, in terms of behavioral health needs, mental health support needs, et cetera. The list goes on and on. But why are we continuing to see the proliferation of all of this infection in these communities? And really, it's about basic access to what most Americans may happen to enjoy. That's not the case widespread for people of color. And unfortunately, when we do access any level of health care, it is not with the same intention and comprehension as others may receive. I too have gone through, many of you know, terrible medical challenges over the past couple of years, 2 cancer diagnoses, etc., and having to fight and demand for levelized basic health care, access to all the tests that may be appropriate and cutting edge. That's not offered up as a routine, as it should be, at least to people who may be perceived as unable to pay for it, one. But two, we just don't often get the same compassion and empathetic approach. You have to forgive me. I've been telling everybody because for the past week, I've been knee deep in Dr. Uche Blackstock's her latest book around racism in healthcare and the idea that none of these systems, including the government system I work in, was set up to support people of color. They're not designed to respond to the unique needs of young Black gay men. They're not designed to respond to the needs of young Black, African American, and Hispanic women. They're simply not. And so the ways in which I believe we've got to work very, very hard, with our community members to make them understand that that's a real fact. That's a reality that we're all facing anytime we need to engage or want to engage in healthcare, and that we've got to arm and equip folks to go in there for the fight. Because that's exactly what I had to do. And thank goodness I'm on the survivor side of my cancer diagnoses, but I had to take a stand and make some demands. And on the other side, we've got to engage with these systems, as hard to dismantle as they may be. They're simply wrong, and they're not working for what we need. And so to me, I think that level of a two-pronged approach is necessary. And what I see from my seat sitting here for the last 30 or plus years, it's what's missing.
Dafina, you know,
Yeah.
I mean, all of this stuff has political and policy implications.
Yes.
Right? So there's state level policy implications. There's federal. I mean, we got EHE at the federal level, and that has a trickle down to the states. But we've also got, as Marlene is saying, we've got some states that have expanded Medicaid, other states that haven't expanded Medicaid. What are the policy implications that we should be thinking about around this stuff?
Yeah, thank you. I was trying to jump in and actually want to go back to something that Martha said specifically around sexual health education, because we're talking about how are we missing all of our men and boys in these conversations. And the states, to Marlene's point, that have not expanded Medicaid are also very likely to not have comprehensive sexual health education happening in schools. I have 2 Black girls here in South Carolina who have gone to the sexual education class, definitely in quotes, here in South Carolina, which they've also called the shame class, because they don't talk about sex beyond sex between a man and a woman in a marriage. That is how sex happens. And beyond that, our children are not getting an education around their autonomy. They're not getting an education around how to protect themselves, and the erasure of the LGBTQ plus experience in the context of those classes. So you talk about policy issues, that is a big one. And it trickles down to what we're talking about in the context of prevention in our communities. I will say, when we're talking about policy, it's 2024, folks got to vote. They've got to vote. I mean, that is number one priority, because if we want to see some change and transformation, and we don't want to see things get worse, folks got to get out and get to the polls. We know that Congress and others have started some foolishness last year around the defunding of all of this work that we've talked about, all of this growth and evolution as a result of prevention efforts on the ground, as a result of EHE, as a result of what we're seeing happen in our communities, threatening to take those dollars away, the Minority AIDS Initiative, all this work that is happening, that is led by the communities that are most impacted, that are closest to the disparities and know what their communities need to thrive and to improve. We have to make sure that we are engaging in those conversations. We need a budget that is going to not just stand where we've been, but we need more resources going into our communities, because now with these greater attacks that we're seeing on reproductive freedom, reproductive justice, there's a lot more work to do. This is the ripest time for us to be talking about taking our HIV focused justice work out of a silo and getting into reproductive justice and getting into dealing with our partners who are doing work in housing, who are doing work in harm reduction, all of that, we have to be united in that front. And to the point earlier in talking about, I'm struck again, I'm in South Carolina, so I'm kind of like Marlene in Texas, where I'm like, there's a whole lot going on at one time. And there are so many fights that we need to be fighting. And I know it's overwhelming. So I want to name that too. There's a whole lot of policy issues. And every time we think we're attacking one, it's like whack-a-mole. Something else is popping up. So we can't do it by ourselves. So I would encourage us and urge us to make at least one new friend who is doing focused work outside of HIV and educate them about the necessity of addressing HIV in their work and us identifying ways that we can do the same. So I think our priority right now has to be mobilizing our folks for action and getting to the polls, and also mobilizing ourselves and de-siloing our work and working in partnership with others who we all really want the same thing. We want our communities healthy, we want people to be safe, and we want our folks to thrive. And so those who are like-minded, we need to be out here doing this policy work together.
Can I jump in there real quick?
Yes, Marlene.
Toni, especially since Dr. Fanfare is in the process of, setting up her priorities. I'm going to bring out a couple buzzwords, that have been going around in the community that, originated from the CDC and Dr. Fanfare's predecessor that are kind of, when I look at it from a research perspective, could be useful. But again, when we talk about the systematic racism that has been raised, it's impactful for our community. So molecular health surveillance, right? You've heard this. They talk about cluster detection and response. And so they're using our genotype, our resistance testing and genotype testing, and they send this information to the CDC. And we know that when they identify those clusters, I hate that word, but those clusters are among our people. They're among Black people and they're among Latina people. And they're being, once they're identified, then, they identify all these other issues and end up being associated with, all these other things that are going on that should come from a point of harm reduction, but in the end, they end up getting our people criminalized. So, so please be looking out for, the discussions that are around that. And then there's also the status neutral approach, which has been great. A lot of us in the community, a lot of us that have worked in services, we've seen literally people in our communities who are wishing they were HIV positive so that they could get some of the food and the services that the HIV positive people are getting. Because other than that symbol, that status, the positive or negative, our people are facing the same issues. They're facing the same issues. But I think where we're kind of really worried is that the infrastructure, and they're saying, no, we're not going to use any Ryan White money or any HIV money, but they're saying, oh, but we can use the infrastructure. And, forgive me if I'm not as educated in thinking infrastructure equals money, right? Like money was spent on the infrastructure. And so we want to ensure that we continue, as we have already said, continue focusing on trying to make sure that people living with HIV are not only being stuffed with pills, but they're also getting a decent quality of life, which is the last thing I'll say. You already talked about aging. The research is showing all the care that we need. The research is showing how we're aging, what is going on with our liver, with our heart, with our mental health, the fact that we're isolated. But this research that has been going on for 30 years somehow does not translate into A, policies, and B, care. It's just not translating. And for me, that doesn't make sense because you've known for years what is going on with us, what is going on with our bodies and all the things that are happening with us as we age. But somehow it hasn't changed the way healthcare is being delivered, especially for our people. So I just wanted to plug that in.
So Martha, I'm gonna
the molecular. I really think
I'm going down the molecular road myself, and we can come on back to it because I want to be clear about it that so it's molecular surveillance and clusters that we're being framed as in West Virginia. And see, and I believe that this is actually an outbreak. I also think that molecular surveillance can be risky or tricky when you're talking about such small populations, such homogeneous populations.
Yes.
I think it's really easy to kind of identify who you're talking about. And so, again, I also think that one of the things I keep looking at is that the variable that we have to keep in mind today in 2024 is the geopolitical climate that we're in.
Yes.
Whether that's the town council, whether that's the city council, whether that's a state representative or a state government or the
School
federal
boards.
government, or if it's global, right? And I think that if we don't kind of factor the geopolitical climate into our
Yeah.
planning, into our thinking, we are remiss. And I think that what happens is that people look at or think about someplace like Appalachia or West Virginia, and it's actually kind of big, but it's actually not big. And again, we're talking about looking at an epidemic from a lens of 2024, but it's really like an epidemic really of 1994, where I don't have the providers, I don't have the infrastructure, I don't have the education, I don't have the past experience, I don't have all of these things. And we've got to kind of build it. But as I think it kind of like what Dafina was saying, is that that's why we'll be hosting the Syndemic Summit May 19th, 2021 at the Greenbrier. If you can come in White Sulphur Springs, please do. We can probably get in. But that we think that the partnership that we have to create is, yes, around HIV, hepatitis C, and substance use disorder, but around economic development and workforce development, because that's the other piece of this conversation. The other conversation is what's going on with the economy in the places that we live, work, play, and have sex. Dazon.
Yeah, so dittos to all of that and what's been said. I think when you first started out this question, that triggered for in my head this notion of the molecular surveillance issue is, and I don't know if Dr. Robin remembers this from a while back, but I can remember before it became a part of the infrastructure of the epidemiology work of the CDC and HHS. I can remember when a study came out at one of the CROIs back in the early 20 teens, where the data was initially brought to the floor around how and that was when molecular surveillance really literally was following the virus and not necessarily people who were living with the virus, which is where it's kind of shifted to when we talk about these clusters. What was important is that it was the science of it was really clear in that question you were asking about heterosexual transmission, if you will, in terms of Black women and their Black male partners. And there was immediate correlation because they were following the actual virus and where it was showing up. And the data was showing that most of these were men who are what I call MSMWADTs, which are men who have sex with men and women and don't tell, right? So if you're going to put it in a behavioral factor, that's where that category sits, right? Now, the question I have when we're debating this, because all of the things that Martha described, and of course the utility of the surveillance tools that we're talking about in terms of molecular tracing, tracking, whatever that is, gave us information that actually solidifies what we all know and say in our communities. The question I have, though, is how then do we hold our brothers in our communities accountable without engaging it from a judicial or carceral perspective, right? How do we make sure that that accountability is there, that we have a way to deal with that we have a way to address it, that we have language for it, that we have space that's safe enough for it, without using the negative and the adverse impacts and outcomes that molecular health surveillance will do for us. The other thing, because I love the conversation about sexual health, there is never going to be a day where I trust, because it's all localized, where I trust a public school system to educate any of the children in my community properly around sexual and reproductive health. Never going to happen in a way that's going to be equitable, just, respectful, inclusive, and all of that. So there's a whole nother level of talking about community-based sexual health education and well-being, so that in a given community that we're able to educate the grandmas, the aunties, the mothers, the fathers, the students, the children, the business people, the faith leaders, the barbershop owners, everybody within a given community is getting the opportunity to learn and have this information. And then the last thing is we've already seen what success looks like in achieving the end of HIV for white men who happen to have sex predominantly with other men. So what was it? What did they have? What did they get? They got investment. They were centered in the messaging. They made sure that there were services where they live and breathe and how they needed them. Whatever was working for them, it ain't got to be exactly the same thing, but it's got to be the same stuff. You know what I mean? It's got to be the same approaches that make sure that we get that. So that's part of that equity is where is the equity in the success metrics in terms of HIV?
But Dazon, I think you hit the last piece of this, right? That you kind of talk about. Okay, where is the equity? A couple of things happened though, right? There was access, and there was a privilege and power that happened there too.
Yes,
You know, because
exactly.
so what happened is that there was a divide that also occurred with HIV. Some folks then went off into when HIV started to brown up and feminine and get more feminized. Those folks went off into the marriage equity movement. They took
Yeah,
their
that's right.
treatment outcomes and went on. But the precursor to that was that they were in positions of power of whether or not they were public about their being gay or not
Right.
being. I was trying to say it politically correctly, and that never works for me. So, so many of them were closeted and in positions to make decisions around finance, whether they worked in the congressional office or whether they worked in the federal government. But they
Yeah,
knew people and lived with people, or were those people that
right.
benefited from that. So I think when we see people that are getting in positions that maybe can make different types of decisions, that's why I
Right.
say it's critically important that we support and not sabotage them in
Oh,
those positions
absolutely.
as well.
Well,
Now,
you're actually hitting it on the head, Toni, because
hang
it
on,
is
one person,
centering.
right?
Centering is that whiteness was centered
Right. But
because
so
they were
one
able
person
to do
hasn't
that.
talked at
Right.
all. And one person hasn't talked at all. And she always got everything else to say, but now she ain't got nothing to say. Yeah, that's what I'm talking to you. You always got your yap in my ear all the time. Now you're quiet. Yap. Stop click clacking on the computer and say something. You the one running the clinic. Yeah.
Okay, so I'm not click clacking. I am over here deep in just amazement. I mean, just to listen to the conversation. I will say this, and I'm not quite sure which hat I'm wearing, so I'm glad when I had a chance to, when I got kicked out and had to come back in, I put my name and not my job email. Um, but as a positive woman who had to, birth a kid in 1995,
Mm.
and that dance was very very different than what it is today.
Mm.
I was awash in information. I was educated regularly. There were I mean, and there, even though it wasn't as robust, the will of the community to engage looked differently than it does now. um I had a kid. I went through, that whole piece of, why are you having a kid? You're gonna die, or your kid's gonna die. That was a reality, but there was a community that said otherwise, and demonstrated and showed otherwise. And I do often think, having gone from, oh my God, can I have a kid, to now I'm at aging and HIV. I mean, that was it went like that. And what were some of the dynamics that really registered and made a significant difference? Dazon said it, beauty shop, barbershop, hip hop, I mean, we were any and everywhere a message could be shared, we were everywhere. But I also know that now, as a um, leader in the FQHC world, who had to go take an organization from an AIDS service organization to an FQHC. It
Yes.
was a dilution of resources. It was great because the organization was able to survive. So I say that to say there are so many other variables that I'm recognizing. Like, man, how deep are the layers? I went from a city in Houston with Marlene to a rural county, an hour and a half away, and the dynamics completely shifted, absolutely shifted. Um, you can't, we have a P flag, AP flag, AP flag for Southeast Texas. That's 6 counties. AP flag. So when we talk about what do we need to do, can we get some more? And this P flag is not necessarily targeting or hitting the community that we're talking about. And is there intentionality in doing it? Maybe. Is there effort being put into it? And so, same thing when you talk about women. I went into one of my counties, went to talk to the high school that was for all the black community, and I said, "Hey, we're right down the street." Oh yeah, we don't really go down that way. Why, Jesus? Why don't you go down there, right? So there are other when you're talking about a rural community. I agree with everything everyone said, living in a big city, living where there are resources. We don't have EHE money. We don't have none. We can't get any. Yeah, so we have other variables, but I will add, I like to be able to cheerlead and remember some of the things that we have done right and that we are continuing to do. One of the things I'm most proud of is I have diversity and my medical team. So I have black women, white women. I need a brown woman. I mean, we're open to having everyone be a part. And my medical director is also a dual certified HIV provider. So we're able to still do the work. There are still people going into the field and seeking to be a part of this epidemic. And black women, I think, are leading in that space as well, which I think it says something for addressing other issues, like, can I get you to the clinic? Can I get you from here to the clinic? Because you can't go out into a rural community and have an HIV camp. Not today, not today, not today. They're not coming to that. Like, they're not coming to a mental health either. And this is no disrespect. I live here and I love it. But in reality, what do we have to do now? Um, to ensure that these messages get fully across, and I'm learning it's an integration of discussing that whole fullness of what it is to be a woman, whether you're a mom, whether you have a chronic health condition, whether you have a new diagnosis. It's about making sure we're targeting and responding to that full need. And I'll say, as an FQHC, I think, I thank God every day he took me from a system that was so robust and put me in a system that's the exact same system, except for it's designed to ensure that you're reaching all parts of the person and making sure that you have that solid home for them. But I just say, that rural conversation, that rural piece, um, it opens your eyes to, wow, there are way more layers to this situation. Never mind geopolitical, whatever. In that space, sometimes you're literally the last thing people are concerned about.
Right. Right. No, West Virginia doesn't get any EHE resources. We tried to pull the lever to say, hey, we have an outbreak provision, but if you can't get outbreak money if you've called it a cluster now, can you? So it's six one way, half a dozen the other, right? Because there's an outbreak provision in pillar number 4, right? But it's not been called an outbreak. It's a cluster. So and I could go on about that, but I
And
won't.
Tony, the
But
other
I
thing I just want to add too is one of the reasons why being in these kind of spaces for me is such a big deal is because there is an intense sense of isolation in rural communities when it really talks about what's new, what's coming, how do we advocate together, how do you do that? And so I think that's another piece I just add to that struggle is, you got to reach kind of far to sometimes find a friend that really understands some of the challenges that we have going on in rural areas.
Rurality ain't no joke,
And
Marlene.
I wanted to add to Dena's resource allocation conversation. Again, in my seat, providing governmental public health, responsible for responses in these communities who are hardest hit by the subjects that we're talking about today. And the idea that, we're so siloed with the ways in which these resources are distributed throughout the nation, throughout the states, through, down to cities and counties. As we all know, they come in very specific investment silos. The idea that this prevention dollar can only be spent in prevention ways, et cetera. We've got care dollars that must be spent in care ways, and the list goes on. And I think we've got to develop a push-pull strategy. It's one of the things I've been trying to advocate for at the local level, the idea that we certainly need to have these existing silos act more robustly and more creatively and innovatively. The idea that you can sort of create a better or more well-rounded approach, either through direct allocation of resources to do so, or through partnerships, collaborations, coalitions, et cetera. There's a way to do our existing siloed allocations better and more creatively, and vice versa. We are missing the boat if we're not going after education, if we're not going after those other silos of funding. We are also missing. So I think we've got to both push in that direction and make sure that we've got partners and colleagues that don't speak our language, that don't understand our acronyms, and are really at a loss about how our communities are being devastated by HIV. I think we spend so much energy talking with ourselves, and we know what many of the challenges are. But every time I have a conversation with a colleague from a different sector, we sit in the technology and space epicenter here in Houston. They have no idea what we're talking about in terms of what's devastating and impacting our communities, and why your workforce may be disrupted, and why so many other things are impacting their sectors and their ability to get the work done. So I love what Dena shared about the resource piece. And I think if we don't figure out a way to help ourselves talk about that more and demand more, I'm all about educating and empowering communities to be able to take charge, take care of their own health. If you give me the information, I know what I need to do for me. And so as much as we can, share, righteously about the facts as we know them.
Uh-oh, you went on mute.
Yeah.
Sorry about that. Sharing with people what we know works, making sure that they understand, as Dazon laid it out. There's some things that we know work. We have the tools to end the HIV epidemic in this country, but my God, they have not at all been available or at scale for communities of color the way they have been the past 30 years in other communities.
Right. But I think that, for me, I wanted to say this is that's, I mean, and I know, it's shameless self-promotion, right? But it's why we're hosting the Syndemic Summit in May, is because I really felt like we had to have a different conversation with the business and economic development community, particularly in rural America, because the first trigger isn't going to be this HIV piece. It's the substance use disorder piece. And if I can't get you to see the one piece, I got to get you to see the other piece. But I really also feel like we've got to get them to understand also the economic impact of disease, right? So can I get these MAT providers to understand, if you scale up HIV testing, if you scale up hepatitis C testing, if you scale up linkages to primary care for things like annual physicals, first and second trimester maternal child visits, if you do those things, what you can do is increase your bottom line, number one. But number two, the other thing you can do is that you create this ecosystem of a client, of a consumer, where you are actually getting to meet their needs. The other piece we can add around that is around immunization, having a different conversation post-COVID around immunization. And in rural communities, that immunization conversation, particularly for childhood and adult immunizations, particularly for seniors, is a difficult one to have post-COVID. But again, the person who's got their hands on that family. And I think it's the social, sexual, and drug sharing network that we need to be having conversation with, particularly in rural communities. And Dazon, you said something earlier, or at least I think it was you. And the thing it brought to mind to me really is the piece that Ada Adamora had done. When Ada looked at kind of where it was, looking at where Black women were having sex and what the sexual and social sexual networks were.
Right.
And like, if we could do two things, right? If we could actually infuse information, screening, testing, linkage to care into those networks, and then also extract information from them. What are your patterns? What are your behaviors? What do we need to know to educate within that cluster? And what we found out in those clusters, in those networks,
Oh,
right?
stop calling them clusters.
I just stopped myself. I just stopped myself. I was just in those networks, in those nodes, in those networks of social and sexual behavior. What we found out was that if we could infiltrate them with information, testing, linkage of care, and treatment, what we could do is diffuse it, right?
Can I add one more thing that you can infiltrate in there? And you all have touched on it in terms of workforce, in terms of empowerment, in terms of knowing that our underlying issue with our communities is poverty, essentially. And that is employment. I'm associated with an organization now that is talking a lot more about employment. And our people, our impacted people, are not going to get employed as well to increase their quality of life. You're not, even if you increase all those services, if they don't have transportation, they're not going to go there. Somebody else talked about in the rural areas, if the first thing on their mind is not care, but it's food or something else, they're not going to use it up. And your CDC MMP data said almost 50% of our people are either unemployed or not, yes, underemployed, whatever those terms are. Literally half of us. And when we've gone out into the communities, we know why they're underemployed, because a lot of us who are aging with HIV at some point when we thought we were dying went on disability, and we don't want to get off of disability because we don't want to lose any of our checks, anything that comes to us. I will work that job in a grocery store for as long as I don't get off the 1,000 a month check so that I can still get food. And this is what I say, like, it's in the data, right? But how come we can't even add just employment services, employment counseling, just support within the Ryan White system among especially women who are carrying their families, elder care, child care, grandchild care. We can't add that. And there's literally, with labor laws and all this stuff, there's literally ways that you can ease off of unemployment and so on and so forth, disability, and be able to find gainful employment that gives you a quality of life. But the CDC and HRSA won't allow us to counsel, even, and this is across the board, it's a great resource for people who are at risk for HIV, because then they stop having transactional sex or sex work, which is work, but you can get, you can get work that gives you a quality of life and doesn't put you in danger, and so on and so forth. So there's that conversation too that needs to happen.
And Martha, what I would say is that's why we've been doing a lot of work to engage the Department of Labor, as well as the Department of Education. The Department of Education, because they're in charge of vocational rehabilitation services and a lot of the voc ed. So we've been really going to them and saying, hey, you guys have skin in this game too. And the same with the Department of Labor. You've got skin in this game too. And what we've done is that we have historically let them off the hook. Even when the HHS had the what was it, the old group, it's called the Syndemic Working Group now, but it used to be called the National AIDS Strategy Group. Department of Ed didn't really come, nor the Department of Labor. All the other groups came, all the other agencies came, but they didn't. But they've got real skin in this game, particularly now with the economic impact. And that's what we've got to hold their feet to the fire, because I don't know that HRSA, Ryan White's supposed to be the payer of last resort. And we've got to remember that. It is not the payer of everything. And I'm no great defender of the government, But what I'm saying is that's what it is. That's what the statute says. Now let's go to the people who have other responsibility. I got to
Don't
get
you think that should change, Toni? Like, don't you think Ryan HIV care should just be accessible to everybody? Like, seriously.
Yeah, well, I think the Ryan White
Why does it
system
have
is
to
the
be
blueprint
public?
for universal health care, right? I mean, all the way down to the Part A giving the locus of control of how the money gets spent, right?
100%, Dazon. 100%.
I mean, when you look at all of the people, the health outcomes, the viral suppression, where we're trying to go with the whole care and prevention continuum, it is for those who are within the Ryan White system that their outcomes are better than anybody else's by a long shot. So I think that that's important. I knew you were getting ready to do something, Toni, but there's another pivot that before we, finish whatever our time is that technology is already way in front of us, whether it's AI or anything else. And when you a lot of the questions that you were just asking, Toni, in terms of the networks, in terms of reaching people, in terms of who's reaching, what it looks like. Okay, just on one little metric, of the top 10 global social media influencers in the world, right? The top 10 Black women who have gazillions of people following them. Of the top 10 Black women social media influencers in the world, 9 of them only do beauty and hair. Okay. So when we start talking about how we're bridging and not just meeting people where they are, not just meeting Black women where they are, but meeting Black women where they want to be met, I will tell you it is not necessarily in the beauty salons themselves. It's actually in the social media where all this hair technology and the technology around hair and around the makeups and around the beauty is actually happening. And we are nowhere in those spaces, right? So, how do we make sure that where people want to be met in what they already attach themselves to and follow, and this is at an industry level, that we have to get more engaged around not just the HIV, but the overall sexual health. Because for the most part, honestly, if we're being real about it, the reason that we're spending all that money on sex and hair is so that we can look and feel good and obviously be attractive to somebody else. To what end, that's on them. But y'all know what I mean. It's usually to get the get. So
to get the get? What's the get? What's the get? What's the get, Dazon?
I want to be flued somewhere at some point. I'm just saying. So yeah, I mean, just sex is the beginning and the end of every single thing in human life.
Well, it's what I say about it's what I say about PrEP, right? Like, why do we keep having conversations about PrEP with Black women in clinics and church basements? Why are we not going out to the beach party weekend? Why are we not going out to the club? Why are we not going out to the places where people are thinking about sex?
And so I know you, Toni. I know you're being facetious, but I think it's not an either or. I think
I'm not being
facetious. A lot of folks at church have sex.
No,
that's
I'm
why
not,
I met
no,
my
I'm
best
not
boyfriend.
I'm not saying that they don't have sex. But what I'm saying, Dr. Fanfare left. She like, I'm not playing with them today. But what I'm saying, but I'm not saying don't have them there. I'm not saying. I'm saying let us be more. We need to widen it. I mean, we still have Beach Weekend in Virginia Beach. We still have we don't have Freaknik on the scale that Freaknik used to be, but we still have those opportunities. We still have opportunities to leave people with a message to make them, when they get home, go, huh. And
so may I offer this, Toni?
You may offer anything.
One of the things, as an HIV system, I think many of us fall short because we talk about HIV as if it's separate from sex. I think if we have conversations around healthy sex, pleasurable sex, happy sex, woman-centered sex, then we're able to have conversations that people would be more apt to tune in, that women in particular, Black women, would be more apt to tune in. If we
Right.
talk about ways that women can achieve orgasm while still preventing against contraction of HIV or transmission of HIV. I think if we're able to have these types of conversations, if we're able to say, certainly you can continue to have sex with Mr. Charlie, or you continue to have sex with Boo. Here
And we would
ways.
pack the room. We would pack the room. So I
Right.
think you're
pack the
absolutely
room.
right.
Yes,
And
and that
and again,
goes back to what you
that's
was.
not a new, that's not, you know, that concept is so not new. It's exactly
Yeah.
what has been done before. The question is, why did we stop doing some of those interventions?
Because we
We
got a lot of
put
money to not talk about sex. We got money to talk
Yes.
about HIV.
Medication.
That
Yeah.
yeah, this is, in my opinion, this is one of those panels where there's probably too much power, because I would love to sit here and listen to you all without talking, but since I'm here I might as well talk a little too. And I think that's it, what you just said, Dena. In my opinion, we got money to talk about HIV but not to talk about sex, and that is a huge thing. I can tell many women can tell you the risk factors for HIV. Many women who don't have HIV can talk to you about the risk factors of acquiring HIV. But what they cannot tell you is how a person who has HIV is able to have sex with someone, condomless sex with someone, and not contract HIV because they don't know anything about you equals you.
That's right.
Or they've
Right.
heard it and not really sure what it means. Or they don't know what undetectable is. When I first started dating my ex-boyfriend, we were talking about, we were doing all kinds of disclosures, and he was like, "Well, I researched and you're undetected." That was the word he used, and I thought that was absolutely hilarious and also scary at the same time. But it was a conversation that we have, and now I'm able to, and I'm using myself as an example. I'm able to send people information on PrEP and injectable PrEP options if they don't want to take a pill. But we don't talk about sex enough, in my opinion. Even at the beginning of this conversation, and I wrote a note to myself, there were several of us who used the term having sleeping with. And I almost came off a microphone and say, I sleep with a whole bunch of people and have not had sex with most of the people that I slept with, so therefore couldn't contract HIV. We aren't, even then, we were watering down what actually was happening. You don't get catch HIV, and I know what I said. You don't catch HIV from sleeping with somebody.
But so that I think that you are 100%. And I'm going to end this where we started this. One of the challenges since I've been in this game, you can see we've been around 30 years now. Dazon been around 35. Women have always in this disease, in this epidemic, in this crisis, in this dilemma, been seen as or perceived as vectors of disease, vectors of a problem. And so until we see women as whole, right? Whole, sexual, healthy sexual beings, sexual, whatever you are on the range of your sexual exploration, identification, all of that. That's the first part of the challenge. I mean, we could go back to the U.S., the United States being puritanical nation and all of that. We could do that, or we could talk about the reality of it. Is that, and then on the other end of it, you've got the hypersexualization of Black women. So that's a whole nother piece to the dynamic. Now, look, I know we started late, and that was on me because I'm old and I got messed up the technology. What I want to do, Dena, you didn't have to you didn't. You didn't. That was unnecessary. Truly unnecessary.
and the words that went with it was that part.
Yeah. But unnecessary. But so here's the thing. What I want to close out with is this. Our greatest success, our greatest challenge ahead, what you're going to do about it, and what we can count on you for. However you want to mush that all up, but I want to hear from each and every one of you, because it's bad, but it ain't all bad. It's good out there, but it ain't all good. And I'll say this before anybody else needs to say it, but if push come to a shove, I just want each and every one of you to know, all you got to do is say, I got a problem. I'm gonna bring a shovel. I'm gonna bring a cup. What the situation was, I don't need to know. I mean, I'm gonna ask on the way back, but I don't need
You
to
say
know.
a cup?
I don't
Did you
need to
say
know
a
what,
cup?
huh?
Did you say a cup?
I didn't say no cup.
Oh, I heard shovel and what?
A car. What's wrong with
Oh,
you? How much
a
of that?
Oh, I
car, a
heard cup.
car.
I heard
I heard
cup.
cup.
I heard
I
cup
heard
too.
cup.
Okay,
That's
see,
how we
look,
were
okay,
drinking.
y'all don't
I
need to
heard
bond.
I
Y'all don't
heard
need.
some.
Thanks, ladies. Thank y'all.
Y'all don't need to bond like that, okay? Y'all don't need. I ain't nobody need all that. Nobody need all of that. Here we go. See, here I go again.
At some point, it ain't everybody else, Tony. Can't be.
See, Dafina, you and I just started getting along. You ain't had to go with the.
I mean, the truth is the light. So
And
We
that's
are all
that's
speaking
that's
truth to power
that's
right
all
now.
raw.
We're
That's
speaking
all
truth
raw.
to
So,
power
and
right now.
Tony.
that's
Oh,
right.
Okay, I can start. Oh, go
Yes,
ahead.
please. Go right ahead.
Okay. Well, I was going to say I maybe did want to echo what everybody has said in terms of we've come a long way. And I think the numbers are showing that. And the work that is being done to find all the information and all the research. I think our greatest challenge is to stop looking at us as numbers, and because that's what we've become. It's this amazing data, and as people living with HIV or in the community, we need to disrupt, the same way we had meaningful involvement of people, greater involvement of people in all the policy and advocacy spaces. We really need to disrupt the research space because certain people, we don't need to be dying of certain things when something can be done about it. Something can absolutely be done about the comorbids, about this, our struggles with isolation, about mental health. It's all there. They're writing amazing papers about us and sharing them at CROI and International AIDS Conference, and it's not translating into care for us. That's our great challenge. What am I going to do about it? I'm going to keep standing on top of any mountain I'm invited to and telling people about this data and the research and what it can actually do for us, that it can actually turn into policy and turn into services for us for a better quality of life.
All right. Thank you, Martha. Who
Thank
wants to go
you.
next?
I'll go next. I think we've touched on it throughout the conversation. Our greatest success is centered around the science. We've learned so much about what works to end this epidemic in the tenure that I've sat in these seats, and the idea that we have seen resounding successes in certain parts of our community and around the country. I think our challenge centers around some big isms, racism, these systems that are not uniquely designed for the unique needs that we have as Black women. So comprehensive care is what we've talked about quite a bit. So I just really want to echo that and leave with that. And then, my hope centers around being able to empower more women, to equip women with tools and information. Tori put it best. How can I be me? How can I do me? My all encompassing sexual me, and do that in a way that I can continue to thrive, I can continue to live, and so on. And so many of our communities don't know how to do that. And then lastly, listening and being led by community. And that's what I'm going to continue to do. The idea that community has never been wrong in describing what it is that they know they need that will work for them. And sometimes, especially sitting from a governmental public health seat, I want to always intentionally try to not get in the way of that. Communities know best. And so we need to be led by and guided by and listen to that guidance. That's it.
Look at you, the government. Look at the government talking.
We get better. We get better.
I don't, girl. That's all we can do. Be better today than we were yesterday. That's all I try to do every day, girl. You know me.
Well, I'll piggyback off Marlene as another voice of government. I actually think one of the huge strengths we've seen is the voice of community and advocates and activists that have really kind of led us to this precipice where we are, with really life-saving, game-changing biomedical interventions and movements forward. Some of the huge challenges can, there's so many, but if I just say kind of one, is that the communities disproportionately impacted by HIV continue to be the communities that are not able to access those life-saving biomedical interventions. I think also it's been promising seeing the involvement of the conversation around self-rated health and housing, and food insecurity and unmet health needs and overall quality of life indicator. Because as Martha so eloquently said, people with HIV are much more, and we need to realize, much more than viral suppression, right? That can't be the goal. As a provider, I have plenty of people who are virally suppressed, but what's really going on is about the quality of life, the day to day, what it takes to survive. So I think that that's continues to be a challenge. I think for me, continuing to be engaged in conversations like this, I really hope to be a bridge across just not our division, but as we think about this endemic space, what are we doing with our sister divisions in the agency? What are we doing with our other sister agencies, HRSA, HUD, broadening that table, as people were said, people who aren't necessarily quote unquote in this HIV space, but also community, people living with HIV, our partners. It's really important. The private sector that's come up here as well, it's really going to take a broad village at the table to get us where we need to, because for too long, I feel like it's been drip, drip, drip for us as Black women, all women, but I'll speak specifically for Black women, as we still make up more than half of the new HIV diagnoses and the prevalent cases. It's really important that that focus be centered and intentional. So I just want to thank you, Toni, and thank you everyone who was here for welcoming me into this conversation. I've taken a lot of notes, and I know some of us will be having conversations either later this week or at Pacha, but I think everybody has my email, so to please know as things come to you, it's really important to reach out. I want people to feel like they have that connection, because you all do. Respect all of you so much and look forward to working in partnership with you during this time.
I can't just add one thing to what you just said, and I think this for you and Marlene, and I always talk about this whenever I give a talk or do a training, and that is that I think people mistakenly don't believe government is made up of people. They think the government is this big amorphous thing. It's this big bureaucracy. But I always try to remind them, and that's why we do this thing called the Appalachia Partnership Consortium, where we bring on representatives of the government or representatives of community of organizations and institutions that people think that they don't have access to. So for those that see this now or that may see this in a rebroadcast, I want you to really take a moment and understand what's just happened here is that you have access to the government. This is the government. These are the people that you can talk to and help figure out strategies and solutions to real problems. So again, I want to thank you, Dr. Fanfare, for taking the time out of your Sunday afternoon. And so that's what people think. Well, it's after 5 o'clock. Can't call. No, this is a passion. If it was just that, you wouldn't be here right now. So I want to thank you for that. All right, who's going next?
So I'll go. If that's okay. For me, the success for me as a positive woman, taking off all other hats, the success for me is seeing the increase of women who look like me in positions of power and decision making. Because again, coming from a place where wasn't a lot of us, there wasn't a lot, and when we got together, we had to stay together, and so that representation has grown both in the clinical space as well as at decision making tables, and that I think is a huge success because it just underlines that even though we are moving into an institution, we are a part of it, and we are building those bricks, and we are dismantling, and we are turning the boat a little bit so it doesn't hit head on sometimes. And that's a power, when we think about what is going on with our government. I remember a beloved representative we had years ago, Garnet Coleman, would always say, "Hey, listen, you don't know what I'm pushing up against. You want me to run forward, but right now I'm just trying to hold them back off you." So having us representative and being representative in those spaces is powerful. Where I think we continue to have challenge, and for me, it's in a rural space, and that's wearing my hat as a leader in this in the FQHC space, is being more included and inclusive in navigating where we are and really making a stronger voice for what's going on in the rural communities. I'm looking forward to Pacha. We're trying to get a busload of people to come to Houston just to say we're here and we we're present. What am I going to do? I'm going to stay in my rule lane and appreciate the aging process, as daunting as it can be, but also just continue to use the voice that I've been able to um, develop because of the HIV community. Had it not been for whether it was gay or straight or black or white, them originators, lifesavers. And so to be able to continue in that vein. But I will just say again, as a positive woman, to be whenever I'm with you guys, whenever we're together, it's like a safety net. It's like a blanket because you guys continue to fight. You don't get tired. You don't get worn out. And if you do, you damn sure don't show it. And so to be with you all anytime there's an opportunity, it's just a pure blessing. I love you guys. I love all y'all. Thanks for
Oh,
letting me be here.
oh, ain't
And
that
Tony.
sweet? Ain't that sweet? Ain't that sweet? That's so sweet. It's so
Out-
So
sweet.
I'll
Oh,
go next. So your the ladies who carry the biggest bats can go last. So a success for me. So epiphanal moments in my life have included understanding that healthcare systems don't give a crap about women like me. Education systems don't give a crap about women like me. And even the gay rights movement don't give a crap about women like me. Once I realized that, and I know that sounds like a negative, but it was one of the most positive things that ever happened. Because the truth is, they don't give a crap about y'all either, because you black women. And so the success came from the fact that I realized that if I wanted to be healthy and happy, because those are two separate things. If I wanted to be healthy and happy, and also ensure that women like me and women like y'all and women like us were also healthy and happy, that I had to make sure that those three systems that I just named, but also other systems like banking and mortgages and employment systems and social services, that they started to care and then put their money and their actions where their words of care were. And so that we became not just part of it, but we became a priority. And we continue to do that. And so a success is that I'm incredibly honored to be amongst you all, to be able to be one of those people fighting to ensure that women like us are being incorporated into every conversation, incorporated in decisions, and continue to be. I don't even want to use the word place because it feels like somebody's giving us something, but continually earning positions of power.
Claiming.
yes. Yes.
Dazon.
Ditto. Done. No. Thank you, Toni, for bringing us together. I love these conversations. I think that we don't have them enough, even though we had a really, really good one just 2 days ago. We made it what it was. Thank you, Tori and Dafina, for your amazing leadership in that conversation. I think the greatest, and I want to circle back around to that from what we're going to do, but the now for almost 40 years, the greatest success, and it continues to be this micro series of successes that are really huge in their impact, Our greatest success is every time we win our fight for recognition, inclusion, attention, a centering, resources that are meant for us. Every time we win that, because it's a war for the end, but so there's all of these multiple battles along the way that started, for example, the 1990 to 94 ongoing battle just to get women included in the AIDS defining guidelines and the definition. And we have still been fighting ever since. But, you know, however many years later, because that was 94, so 30 years later, we are at a point where you can't talk to anybody in government or in industry that's not acknowledging what they need to do and haven't done for Black women in the epidemic. And so this is another win. This is a success when we're sitting in research spaces that understand what it means to center us in the studies and not exclude us, because that's your ass when you leave us out. And and that whether, or if it's in making sure that the organizations that are led by us are seen and included and are now at a table or two, if not all of them. That same success is also our greatest challenge in terms of sustaining that centering, sustaining that attention, sustaining that prioritization, right? That's our biggest challenge, is to keep that going, to elevate it, to escalate it, to accelerate it, and to keep it moving all the way beyond the end of the epidemic. And as Dafina was alluding to, the only way we're going to actually be able to sustain that is to continue challenging and beating back the adverse impacts or all the impacts of the isms in our lives. So I'm going to keep doing what I do, no matter what my job is. I'm going to keep coming up with the innovations. I'm going to keep coming up with, why don't we try this thing and see if it works, and not have to defend or justify it just because it came from a Black woman's mind, because we spend our time doing that too. And then you see something come out from, somebody else. It's like, well, hell, we've been doing what we call, for example, TLC for all, that we couldn't get a lot of funding for a long time. And then lo and behold, some other brilliant mind puts another term to it, which is status neutral. It's like, oh, that's what you want to call it? Well, can we get our resources now for what we already been doing for all this time, but not distinguishing HIV before and after for the women we serve, because they're all women in our communities? Anyway, so one of the things that I want to do is keep this conversation going and to keep the people coming into the conversation. When Helene Gayle was being inaugurated as our president at Spelman College. Ooh, somebody rang a bell for me on that one. Thank you. That we got Helene Gayle as our president. The first thing we did was we said there has to be a community welcome for this sister, because she's taking something to Spelman that we haven't had. And that's this bridging of a Black woman in public health, a Black woman clinician, a Black woman who understands business, a Black woman who understands resources, and a Black woman who also understands how all of this data plays out in our lives and how to bring that into an institution. So we held a breakfast. And as we planned this breakfast, Robin and Dr. Fanfare and Dr. Maisha Standifer and Dr. Cynthia Spence, when we put this thing together, we called ourselves the Black Women Who Heal Breakfast Club. And I think that was, and we were trying to plan a breakfast, y'all. Every call, Dr. Fanfare can attest to this, every call ended up being a conversation like this. And then we had to get back, okay, so who's going to call so-and-so and who's writing this? It had to get back to the business. But every conversation was this, and that's almost every space I'm in. We're supposed to be planning for something, and we end up going deep into our own conversations and dialogues. So what I want to do is keep this going so that we can be intentional about how we sustain that centering and how we sustain that attention for ourselves, and how we make sure that we're not leaving any Black women in the diaspora and on the continent behind in any of these conversations.
Thank you. Dafina Ward.
I'm going to be quick because these sisters have said everything. As far as our strengths, we know what we need. The science is telling us, the data is telling us we need the resources. We know what we need. Our prevention toolkit is broader than it's ever been before, which is married to the challenges that we haven't, the dots have not been connected for women that look like us. The dots have not been connected in our communities. We know the care that folks need. We know that there is not a one size fits all treatment and care plan for folks living with HIV. Yet we have policy barriers to open access to the medications that people need, that they can't work with their provider to get what they need in that moment for their lives. And so that is just an example. We know what we're seeing happen around criminalization in states, laws and policies that don't align with the science. So our challenge is the lack of the connecting of the dots and the connecting of the resources to our communities that need it most. And I mean, I'm probably not going to follow your formula, but I'm going to be quick. What we have to do is stop always coming from a place of crisis when we're talking about this in our community. We want our folks to hear us, but if we're always coming from a place of where we are deficient as community, I don't think we're going to see the transformation that needs to happen. Just as we've talked about these systems of oppression and the generations of oppression that we're fighting against, there's also a generational blessing and strength that we hold as Black women that we need to help other Black women, rural women, and folks see in themselves to get us out of this crisis. So my commitment is to not gatekeep transformation in this work. There's a lot of gatekeeping. Marlene talked about the silos, and yes, there's better allocation that needs to happen of those resources. But one of the challenges is that organizations and folks are being allowed to be gatekeepers in communities, and the folks who really hold the solution aren't getting the resources. So I'm vowing not to be a gatekeeper. I'm to continue to work in partnership and to always lift up and center the voices of community who knows what we and they, all of us need, and to support disruption. And my commitment to the women on this call is I am here for you. So many of you have been there for me. If you need a Kleenex, if you need an ear, if you just need to vent, I got a bedroom, if you need respite, I'm here for you. So you call me before you do the thing that requires Toni to bring that shovel and that car and that empty trunk. I got you. And Toni, thank you so much for this space. It's been really wonderful.
Well, I want to thank each and every one of you. And so I will close by saying a couple of things. One, I think where we've been successful is that there is an office on rural health at CDC now. There wasn't one before. And the advocacy of Community Education Group and the National Rural Health Association got that person there. So I'm very proud of that. I'm very proud of that work. I'm also just very proud to have been able to call all of you a friend. And Dr. Fanfare, I'm going to move that now into your onto your CV as well, a friend of Toni's. But most importantly, one of the things, and Dafina, I'm just going to talk about it here. One of the things I've been talking to Dafina about and some other people is that we really do need to have a space that is our space, a women's space, a Black women's space, to be able to have a conversation, not just about the work, but about how we going to retire, how we plan for that. Can we bring in somebody to talk to us about money management? And Marlene, I know you got to go, but Marlene, you're going to be a part of that group too. And so what we need, how do we plan? How do we find interns? How do we create a pipeline? But how do we have a private space where we can just decompress? And the other thing I want to try and figure, do y'all remember when I used to do National Women and Girls and y'all got the watches and the hourglasses and all that stuff? I think we should do that. We need to bring that back. I know that was the Office on Women's Health, but I think we should bring that back. We need a connected thing on this day, National Women and Girls HIV/AIDS Awareness Day. We need something that connects us again. But most importantly, again, I just want to say thank you. We also need to talk about trauma back. Yeah, I mean, exactly. We need to talk about the stuff that we go through too. It's because it's real, and y'all know my story of the last year. I mean, who would have thought, I gotta keep telling y'all that I was gonna be the voice of rural America, of Appalachia, and I'd be talking about gender-based violence. Who the heck thought that? I mean, come on. You saw me talking about a pickup truck first, but
I didn't have it on my bingo card. No.
No, see, and there you have it. So we don't know what life is going to hold, but I know I can tell you, I know one thing. I got each and every one of you on my shoulder, in my hip pocket, and alongside me, and I know I can pick up a phone and call you. So I want to. So those of you that joined us today, thank you. We're going to be cutting this up into small pieces, long pieces. It'll be on YouTube and some more places. But most importantly, I want to thank each and every one of you for taking an hour and a half out of your Sunday to chit chat with us, to educate some people, to share with each other, and to honestly just to be in community.
Amen.
And again, congratulations, Dr. Fanfare. And if I hear anybody call you Robin,
thank you, Toni. Thank you, everyone.
okay.
Oh, when we at
It
the
was
bar,
good
I'm
to see
calling you Robin, though.
everybody.
When we're at the bar, I'm calling you Robin. I'm just saying that now. That's my disclaimer.
Okay.
Martha, I'm going to be reaching out to you, Martha.
All right. Cool beans.
Oh,
Everybody have a
Marlene,
great rest
yes.
of your Sunday. Have a great rest of your
Bye.
Sunday. I'll